stored in cardiac tissue. Can anyone tell me what could be the clinical relevance of the drugs which accumulate high volume of distributions in some tissue? Anyone? Can you correlate this relevance? Yes, Rusil?
Ma'am, for example, levodopa.
Just you explain the chloroquine. I have given these two examples that chloroquine will stored in retina tissue.
Yes.
And imipramine will stored into cardiac tissues. They have
Yes.
high volume of distributions in this tissue. Okay. So
Yes.
what could be the clinical implications here related with chloroquine and retina? Yes.
Ma'am, there will be the drug overdose. Storage of the drug will be more in tissues.
So what will be the, yes, that is true. So what will be the clinical implications or relevance?
Ma'am, I think there will be the saturation point of every drug in the tissues. So,
okay, that
so whenever
I mean, wait, that will come later on.
yes,
जो retina में store हो गया है, here again I am leading clinical implications. Let me ask some other student, then I will explain it. Anybody would like to say? Yes, very good. Rutam said, Soumya said retinopathy. Very good. See, Rutam said we need to monitor the dose accordingly. That is the clinical relevance. Rushil, what you said, that is correct. But chloroquine, it is stored in retina. Now,
yes,
there is a, if somebody is giving higher dose or toxic dose can lead to retinopathy or retinal damage because this drug has tendency to store into retina. Fine. So that will drug remain into the retina for longer time, may damage the retina. That is the implications. Same like imipramine. It has tendency to store in cardiac tissue, antidepressive. So now there is a chances of cardiotoxicity. One has to monitor the comorbid conditions. Okay. Suppose cardiac patients, you are prescribing imipramine, you should watch. Of course, for every drug, there is a therapeutic dose. But if there is some overdose or toxicity may lead to the cardiac problem because that drug is stored into cardiac tissue. That is the relevance which I want to give you all. Fine. Now, there is another the other relevance, that is the drug. Please understand again. The drug which is having high volume of distribution, one has to give loading dose to achieve therapeutic concentration. Okay, please understand that. Can anyone explain this statement with regarding chloroquine? Who would like to say explain this term? The loading dose to achieve therapeutic concentration for chloroquine. Anybody would like to explain this? Okay, let me explain this. The drug who is having high apparent volume of distribution, then to achieve the therapeutic concentration, one can give the loading dose. Here the question is, what is loading dose and what is maintenance dose? I told you I will let you know in my last class, but relevant to this, I can say that chloroquine, which is given in malaria. Now, patient who is suffering from malaria, chloroquine dose, it differs. Okay, I'm just giving example that it is available in a 250 milligram tablet. Now, there is a per day dose is confirmed. That 600 milligram per day first day chloroquine dose is there. Now, among this 600 milligram, one has to give in a first time loading dose. Okay, so मान लो कि 600 milligram है, then you have to give 400 milligram maybe in a loading dose and then divided in after 8 to 12 hours the other dose. I'm just giving example roughly. So here we understand the concept of loading dose. At the time large dose is being given when the drug is having high apparent volume of distribution. And the typical example is chloroquine. Yes, Soumya said that it is a dosage when it was given at a higher concentration. Yes, very good. So loading dose is that where you have to apply part. Okay. And the drug who is having high volume of distributions, it is very difficult to remove by hemodialysis. So the drug, suppose highly distributed into the body, and if there is a toxicity, then it is very difficult to remove by hemodialysis. So here the question, I mean the issue or the point is, what is the apparent volume of distribution, what is the pharmacorelevance, and what is the clinical relevance of that drug. There is another parameter which is called clearance, which is related to the distribution. So what is clearance? As the volume of blood which is cleared of a drug per unit time. Remember, blood में से कितनी drug clear हो गई, that volume is considered to be the parameter that is called clearance. So this clearance value, it will predict the rate of elimination of drugs in relation to the drug concentration. Please need not to worry about this statement. Just now you understand that clearance is one of the parameter which is related to the distribution of the drug. Okay. So I am not going to go explain again in detail because these all are parameters. There will be a special one class with the specific examples. So just now remember clearance. There is another term, definition, that is redistribution. See, the first objective, definition of distribution, apparent volume of distribution, and third is redistribution. So what is redistribution? That highly lipid soluble drugs, they distribute to highly vascular organ to the less vascular organ. That is the redistribution of the drug. Again, I am repeating, highly lipid soluble drug initially distributed to highly vascular compartment, and then afterwards it will distribute to the less vascular compartment. And after that, it will terminate its action. Please again remember, the drug who is having this redistribution capacity will have very, very short acting, ultra short acting. If you remember, I told you thiopentone example. Again, you can apply this thiopentone example here. Thiopentone is a general anesthetic agent. It's stored in fat. Okay. But initially it will distribute higher vascular organ, that is brain, heart, and kidney. And it will again entered into the less vascular organ, that is muscle and fat. And then it will terminate its action. So what is the relevance? The redistribution, because of this capacity, there will be rapid elimination of the drug. So drug will hardly give its actions for 5 to 6 seconds or maybe 1 to 5 minutes. So thiopentone, it is an ultra short acting general anesthetic agents because of its redistribution capacity. That is the clinical relevance. Coming to the second objective, that is, what are the factors which affect drug distribution? Say regional blood flow. You all know that if the vascularity is more, blood flow is more, then distribution is very fast or proper. Again, the capillary permeability. All lipid soluble drugs, they will permeate, I mean, they are permeable for all the barriers. Then drug storage, drug store, there are certain drugs which store in particular tissue, as I told you, thiopentone in fat. And there is another example here I have written, that is a metformin, which stores in liver. So what is the implications here? That fat stores and these liver stores, may drug will store for the longer time, may take time to eliminate, or maybe the shortage of action. The other is important factor is binding to plasma protein, and the other is barrier to drug distributions. See, for blood flow, please remember, whenever there is a blood flow is high, then the distribution is fast. Where is the blood flow is maximum in our body? heart, kidney, liver, lung, and brain, it is high blood flow. Perfusion rate is high. Moderate, that will be in muscle and skin. There is a moderate perfusion rate. And low, that will be in adipose tissue. Least perfusion rate will be in a adipose tissue. So what is the relevance here? That perfusion rate will affect the rate at which the drug reaches to the extracellular fluid of particular site. So here the perfusion rate is very important for the drug to enter into the site of action. Okay, so distribution is that one drug has to enter into the site of action. So the clinical significance of this blood flow, if there is a greater the blood flow, more rapid distribution. कहाँ से कहाँ distribution होगा? The distribution from the plasma into the tissues or the interstitial fluid. Okay, so remember, high blood flow, very rapid distribution. Capillary permeability, no need not to remember here that what is the filtration rate and what are the capillary permeability, but all lipid soluble drugs, they will pass the barrier very fast, or they are permeable, capillary permeable. Again, very important point here, the plasma protein binding drugs. Every drug has its capacity to bind the plasma protein. If you see in a transaction, the cell is made up of a phospholipid, and this layer, there are two sides of that cell. One side there is a albumin, protein is available. One side albumin, and other is alpha-1 acid glycoprotein. These two proteins are there for on the cell membrane of that cell. So what is the important here? That all acidic drug, you can say weak acidic drugs or acidic drugs, they bind to the albumin site. Okay, cell की दो जो site होती है, one is albumin, second is alpha-1 acid glycoprotein. So the acidic drug, that will bind to the albumin, and basic drugs, they will bind to the alpha-1 acid glycoprotein. That is the concept of this slide. Now, what will be the consequences of drug binding to plasma protein? So remember, the drug who binds either in a albumin or in the site of alpha-1 globulin cannot go to the receptor site for its site of action because they are bound. So still it is a bound form, so it will not reach to the site of action. It is a but obvious. It cannot distribute to the body tissue wherever it has to store because it is a bound. It cannot metabolize, it cannot excrete out. Means, what is the consequences of binding drug? Drug will not enter into the site of action, and including for the next process, that is elimination. Okay, so that is the first consequences of bounding. The second is, all bound drug, whenever they are in a bound form, they are pharmacologically inactive. So bound drug rahegi, tab tak that drug is not going to give its action. That drug has to become free from the protein site, then only it will give action. So bound drugs are pharmacologically inactive. It is also but obvious. Then drug binding to plasma protein will delay the onset of action, of course, because it will stay for the site, I mean the protein, at the site of protein bound. So that may delay the action. So these are the consequences of binding of drugs to the protein. The plasma protein binding will decrease the intensity of drug action. So bound drug ka pura hai ki it is a pharmacologically inactive. It will, onset will also delay, intensity of drug will also less. 90% of the bound drug to the plasma protein jo bhi hoga, so that drug may prolong its action. Kaise action prolong karega? Ki body mein it will remain for the longer time. एक तो पहले बाउंड रहेगा, फिर अपने बाइंडिंग साइड से that drug will get free and then it will give its action. So बाइंडिंग जो भी ड्रग होगी वो prolonged action means बॉडी में ज्यादा रहेगी. That is the understanding of these consequences. So more plasma protein bind, less free drug is available. Only remember the free drug will enter into the site of action. That is the statement for distribution. See, there are certain drugs which has somebody was asking why not these drug, why not these drugs. So here, Rushil, can you tell me without?
Ma'am, in previous slide, it was written that when the drug is in bound form, it would give you a prolonged action.
Yes.
Ma'am, I am not able to understand this
See the
statement
bound.
that.
Yes. I will let you know. See, say for example, I have written the example of warfarin. Warfarin is one of the anticoagulant drug, right? Now, uh, suppose if you have given a certain A amount of drug of warfarin, now that warfarin is remain into the body for longer time. Means what? लॉन्गर टाइम मीन्स वो बाउंड है तो वहां की वहां रहेगी और फिर उसकी एक्शन बाद में आएगी. ओके,
Yes,
फ्री
ma'am.
ड्रग विल बी अवेलेबल बाद में. सो वन हैज टू रिमेम्बर यहाँ अपना प्लाज्मा कॉन्सेंट्रेशन इज मस्ट. यू नेवर नो कब वो फ्री. prolonged action is not the efficacy of the effectiveness of that action. Please understand the term. Prolonged
Yes,
means prolonged अपनी body में रहेगी. So one has to monitor the plasma concentrations because we never know that when this drug is going to free. Okay. Prolonged action अपनी आप रहेगी, and suppose if there will be a more amount of drug which can lead to side effects. So the drug which is having high plasma protein binding, one has to see that it will prolongedly live into the body or into the protein site.
Yes, ma'am.
So that only, please remember, only free availability drugs will give its efficacy or its action. Rusil, fine?
Yes, ma'am. Yes, ma'am.
So suppose, what are the examples of drug? These questions we usually ask in Viva questions. I know that you cannot remember just now all the drugs, but just remember one or two name of the drugs, that there are certain drugs. Say for example, high protein bound drugs are warfarin, which I explained. Then salicylate, okay? Salicylate is also highly plasma protein bind drug. So prolonged, वो अपनी body में ज़्यादा time रहेगा. So if somebody is taking without, monitoring the salicylate preparations, that may lead to toxicity. Same like salicylate is, like aspirin. These all drugs are considered to be non-steroidal anti-inflammatory drugs. Furosemide or furosemide, it is one of the diuretic drugs. Indomethacin, that is also NSAID. Sulfonamide, one of the antibiotic, and phenytoin, which is given in the patient suffering from epilepsy. So these are the few drugs which have these characteristics, that is highly plasma protein binding capacity. There is some drugs which does not bind to plasma protein, and they are isoniazid, which is one of the drug for tuberculosis, lithium for the patients of mania, lisinopril, that is antihypertensive, and metformin is anti-diabetic. So these four examples of the drugs which does not bind to the plasma protein. So can anyone tell me that these drugs does not bound to the plasma protein? So what could be the consequences? I told you the binding consequences. इसका क्या होगा? ये 4 ड्रग है. रुशील बताओ.
मैम उसकी एक्शन मतलब बहुत फास्ट हो जाएगी और इफेक्ट बहुत ज्यादा होगी.
एग्जैक्टली. सो क्या करना पड़ेगा? मैम
डोज कम करना पड़ेगा.
डोज तो जो अवेलेबल है वो ही है, उसकी फ्रीक्वेंसी आपको वॉच करनी पड़ेगी. दिन में 3 बार या 2 बार है, वॉट एवर, दैट इज कॉल्ड द फ्रीक्वेंसी. कैन यू अंडरस्टैंड?
Yes, ma'am.
All frequency also depends on the plasma half-life. That is parameter, will let you know. Okay, it is very interesting. But just now you relate these that it is a plasma protein bind and not binding drug, the co-sequences will be the action of that drug related with the frequency. Okay, now one second, somebody is asking me something. Yes, Rutam, giving sulfa drug and warfarin, for example, together can lead to toxicity of either of them. Yes, very good. That I'm coming here. See, Rutam, very good question. For everyone, I don't know, I have made that slide or not. Let me just see, then I will let you know. Okay. See, now coming to this was the relevance of plasma protein binding. So one can say that whatever the plasma protein binding drug is there, they are inactive. It has to free. That is for the single drug I am telling you. Now Rutam question is that if there are two drugs which are highly protein bound drug, and if it has to be given in a one patient, then what will be the consequences? So what will happen, Rutam? Here, these both drug will compete with each other for its plasma protein bind. Now, the drug which is having more binding capacity or more strong, it will displace the other drug from its site. Okay. So here, the displacement therapy can lead to toxicity. क्यों टॉक्सिसिटी होगा? क्योंकि वो ए ड्रग है जो बहुत स्ट्रॉन्ग है, प्रोटीन बाउंड है, इट कैन डिस्प्लेस द अदर ड्रग, सो दैट ड्रग विल बिकम फ्री एंड द ड्रग विल गिव इट्स एक्शन मोर or maybe toxicity. So your question is, suppose sulfa, yes, sulfa and warfarin both are given together. Among these two, 97% warfarin is protein, I mean 97% protein bound is for warfarin, and say for example little less for sulfa. So क्या होगा? Warfarin will displace the sulfa from the site, and there could be chances of sulfa toxicity. Please understand that. Very good question. So this is called the drug-drug interactions. Rutam, have you understood what I said? Is it clear?
Yes, ma'am. Yes, ma'am.
Right? So there are many examples. We'll let you know afterwards. But yes, the displacement therapy is one of the consequences of the protein bind drug. So there are short notes we usually ask regarding the protein binding capacity, its pharmacological relevance as well as the clinical relevance. Please write properly. First read. If you have any problem, you can tell me. The other, there are certain drugs which bind to the tissue. Till now, I have talked about the protein binding. There are drugs which bind to the tissue, and they are this. I told you, thiopenton and benzodiazepines in a fat, chloroquine in retina, and iodide in thyroid tissues. So remember this, some of the examples, it may help during your CET exams or MCQ, that these drugs bind to the which tissues. So these are the few examples. Blood-brain barrier and placental barriers, lipid-soluble drugs, they will pass through this barrier very easily. That is the point for the barrier. So here the key points, if I would say, here lipid-soluble drug, unionized drugs will have higher distribution. Water-soluble drug, ionized drug will have lower distribution. When there is an increased protein binding capacity of the drug, low distribution of the drug. So drug will take the time for its action, that is increased protein binding. And when there is a more volume of distribution, the concentration of the drug will be more. So what are the points to ponder here? I have talked about the distribution, apparent volume of distribution and redistribution. You all have to remember the clinical relevance of these three terms, 4 factors which are important for the distributions, and among these 4 factors, more concentrate on the binding capacity of the drug and its clinical relevance. So loading dose and maintenance dose. And the third parameter is clearance, which is related with the distributions and which is for the quantitative study I will take in my last class. So this is all about the distributions, very important parameter, and again the frequently asked questions. So read, and if you have any problem, we can discuss afterwards. Okay. See, I have written here what is loading dose and what is maintenance dose, but just now, just remember only the loading dose importance. So next class will be of elimination of the drugs. That will be tomorrow. If you have any questions, I am not giving any assignment today because only you read about the binding capacities and clinical relevance. Pharmacology book, in every pharmacology book there are 8 or 9 clinical relevance have been given. You all have to be thorough by that relevance. Anybody has any question? Please let me know. Will have the side effect. Yes, I told you that if it will remain, see, binding drug is binding to the protein, right? If there is a some toxic dose or the more dose has been given, you never know that still the drug is free or not, and then there is a chances of toxicity. So all protein binding drug, one has to watch for the dose, watch for the therapeutic concentration or the plasma concentration. So very important portion here to avoid these type of plasma concentration. Rusil, fine. जो मैंने दिया
Yes,
आंसर,
ma'am.
हाँ हाँ.
Yes,
Now
ma'am.
anybody would like to ask anything? So